Well, that's a very easy to answer question because I'm not using it anymore. And it's been quite a while that we did it. When in the beginning of the century, there were some concerns about endovascular therapy being durable. And we thought there was another alternative, minimally invasive alternative, being laparoscopic surgery. And we tried laparoscopic aortic surgery, but that's very difficult for aorta. And then there's a big benefit from robots to have more degrees of freedom and to be able to sew the aorta. But we did 35 patients, then evaluated the results, and at the same time our endovascular practice was going up. There were very little patients that we could operate on, and training was hard also from nurses. It is expensive, and I think the advantages were marginal. And there are some inherent dangers to laparoscopically approaching the aorta. So that's why in 2007 we stopped doing it. There's basically two platforms. One I described is the laparoscopic platform by making holes in the abdominal wall and then doing the operation. But of course there's also the whole endovascular platform where catheters and wires are being placed by robots. And the big advantages is that there's less radiation for the team, and there's less of trial and error because these catheters are steerable and they go straight to their goal. Yeah, I think especially the second platform can be promising because it could really cut the time of complex endovascular procedures and really reduce the radiation load for the whole treatment team. And that's going to be a important factor for the future, is to protect people against radiation. Yeah, well, at this moment, even with new laparoscopic robotic programs that use artificial intelligence, and I still think the laparoscopic platform at this time is for vascular surgery is not going anywhere. I don't see a whole lot of future there. However, with the endovascular program, but there are still some problems that need to be solved. You can have one wire and one catheter steer it to some point where you want to treat, but you need to change them often. And you also need to be able to apply stents and to do treatment, not just navigation, but also treatment. And there are some platforms that are promising in both directions. If these are things that can be trained excellently in skills labs. So first in plastic models. After that, I think cadaveric training is an excellent option. You can mimic the procedures very well before you go to human patients.